Welcome to Thriving Module 5, IDD and Trauma-Informed Services and Treatment. In the last module, we discussed the role of protective factors, such as a secure attachment and a healing, protective environment, in enhancing well-being and resilience, and how to provide practical tools and support for caregivers. In this module, you'll learn how to enhance protective factors of people with IDD and caregivers through IDD and trauma-informed assessment and screening, and referral to appropriate trauma-informed services and treatment. After completing today's training, you should be able to do the following. Explain how to enhance protective factors of people with IDD and caregivers through appropriate trauma-informed services and treatment. Discuss how to utilize adapted screening, assessment, and planning tools to identify IDD and trauma-informed needs of people with IDD. Discuss strategies for adapting the core components of trauma-informed treatment for people with IDD, and identify strategies for partnering with agencies and cross-system collaboration. It's important for providers to know the full range of services, both IDD and trauma, that a person with IDD may need so that he or she can make appropriate referrals when necessary and help caregivers navigate multiple systems at various points along the way. Sometimes one provider has multiple roles. Most of the time, multiple providers each wear multiple hats. This often means that providers have to be flexible and thinking about their own role. Many providers feel that they are not trained in case management and coordination, but people with IDD and their caregivers frequently need other support in addition to traditional therapy. The nature of healthcare systems results in authorization denials that require advocacy and complicated appeals. This means that providers have to become advocates and insurance experts to get help for their clients and to get them the best possible services. The presence of silos, for example, IDD, trauma, mental health treatment, may each be provided by different agencies, also contributes to multiple providers. The diagnostic complexity of IDD and trauma often results in the involvement of multiple caregivers and multiple hats for providers. The complexity is due, at least in part, to the type and timing of the traumatic experience, as well as how much is known about the trauma. Is it a known trauma, a suspected trauma, or an unsuspected trauma, which may present as a behavioral challenge? A strategy is needed to address this diagnostic complexity, which is interdisciplinary in nature and optimizes referral of the person with IDD who is presenting with symptoms of trauma. So let's talk about an example of how a person with IDD and trauma may be identified and the various service systems they may encounter along the way. Natural supports. Families or care providers notice that a change in mood, functioning, or behavior has occurred, and they may reach out to formal and informal supports for information and resources. Primary care providers, such as general practitioners, advanced nurse practitioners, or physician's assistants, conduct initial history and physical examination, preliminary screenings, and primary care providers hold a unique position in often being the first and frequent point of contact with the healthcare system for an adult with IDD. For example, if there is an injury or a new behavioral symptom, primary care includes performing an initial physical examination and laboratory tests, or utilization of developmental and behavioral screening tools to clarify the etiology and begin treatment or interventions. This process of preliminary investigation may elucidate findings that suggest abuse or trauma, and the primary care provider responds by initiating referrals to protective services, subspecialists, and mental health providers, depending on the indications. Adult protective services. The primary care provider may decide that involvement of adult protective services and law enforcement agencies is indicated. It's important to note, you do not have to wait for a referral from a primary care provider to involve adult protective services or law enforcement. A suspicion of abuse or neglect is all that is needed to make a report. It is the job of these agencies to assess and investigate. Many states have laws on mandated reporting of suspected abuse, neglect, or exploitation of adults with IDD. Crisis support services. Many states have crisis support services for people with IDD through regional developmental services to provide or coordinate services and support for individuals with developmental disabilities experiencing mental health or behavioral crisis. They may have offices throughout the state to provide a local resource to help find and access the many services available to individuals and their families. However, the challenge is that each state has a different system for providing services and even within states, there may be variability in terms of quality and accessibility of services. Referral to trauma-focused therapy. Ideally, the discovery of trauma and associated mental health or behavioral concerns would result in referral to trauma-focused therapy that is appropriate and adapted to the person's intellectual level. It may include psychology, social work, involvement of occupational therapy, and physical therapy as needed to help the person participate in therapy. Referral to informal support or advocacy groups to help the person or their caregivers cope with and constructively address challenging or disruptive behaviors related to traumatic experiences, such as panic attacks, self-injury, or lack of socialization. As we've discussed, not everyone who experiences trauma will require formal trauma-focused therapy. As we discussed in the last module, they may benefit from increased social supports through local self-advocacy groups or community engagement. There is no one-size-fits-all approach to treatment for people with IDD. To effectively meet the needs of people with IDD who have experienced trauma, we need to identify where they are at in terms of both IDD-related needs and trauma symptoms. Screening is often the first step. These are typically less formal assessments and may require minimal training to administer. They may be questionnaires or brief interviews. Screening instruments are typically designed to be very sensitive to picking up symptoms, but not very specific. This means that screening instruments will tend to have high true positives and a fairly high level of false positives. The purpose of screening is to cast a wide net and identify people who are likely to need further assessment, because it is better to evaluate someone who doesn't need services than to miss someone who does. Assessments are more formal and in-depth. They are typically conducted by someone with expertise or credentials in a specific field, such as a psychologist. The purpose of assessments are to collect more detailed information and zero in on a diagnosis. The purpose of screening and assessments is to facilitate the development of an appropriate recovery plan, which may include a treatment plan, service plan, or support plan, depending on the needs of the person and the specific service delivery system. Remember that not all people who experience a trauma will need treatment. In fact, many, if not most, will be resilient with the sufficient protective factors in place. And not all of those who will need treatment will have post-traumatic stress disorder. As we discussed in Module 3, there are a range of traumatic stress reactions. A full assessment will help to determine whether treatment is needed and what kind. Identifying a person's IDD-related support needs is essential for determining the kinds of accommodations that may be necessary to develop a recovery plan. For adults with IDD, they may have undergone psychological testing in childhood, and it may be possible to request records from their healthcare provider or school system. If these records aren't available or are out of date, it may be helpful to conduct a new screening and assessment. The role of the provider when meeting a person with IDD is to understand how the person is currently functioning and how their level of functioning may have been impacted by the trauma. There are standardized screening and assessment tools for this, but information from caregivers is invaluable in the process, as they are often making comparisons between the person and their peers constantly. They have a wealth of knowledge about how the person is functioning and a good sense of their developmental stage and how that may compare to expectations given the person's chronological age. There are many screening tools available, each with its own set of strengths and weaknesses, and each with its specific applications. We won't go into depth on the screening tools that are available, but we will mention a couple that may help in identifying a person's functioning and readiness for participating in their recovery plan. One of the challenges that providers often encounter when trying to use screening and assessment tools is that they have to be purchased. There are a few instruments, such as the World Health Organization Disability Assessment Schedule, or WHODAS-2, which are free to use and may be helpful as a starting point in obtaining information from individuals and caregivers. The WHODAS-2 is a screening instrument, which means that it is not developed to provide an in-depth assessment of the person's abilities or functioning. It was developed to be compatible with the ICD-10 and DSM-5 for determining a person's level of adaptive functioning. It includes multiple versions depending on time and level of detail needed. Another screening assessment that may be helpful in designing the recovery plan is the ARCS Self-Determination Scale. This scale was developed to assess individual strengths and weaknesses in self-determination and facilitate the person's involvement in planning educational and treatment strategies. Self-determination is the right of people to have control in their lives. Too often, people with IDD are not given sufficient opportunities to make meaningful decisions in their lives, and this includes the right to make decisions about their behavioral and mental health care. Further, people who have experienced trauma often feel a loss of control. Reestablishing a sense of control can help to reestablish a sense of safety and promote healing. Therefore, it is important that providers facilitate self-determination as much as possible in the aftermath of trauma. The ARCS self-determination scale has two versions. The original version was designed for students and young adults to assess and encourage participation in their educational and career choices. It was actually developed and normed on a primarily adult sample, although many questions refer to teachers, which may not apply to many adults with IDD. The adult version includes scales measuring choice and control, community inclusion, holistic health and functioning, and person-centered planning and coordination. Assessment may lead to a definitive diagnosis, development of an interdisciplinary comprehensive plan of remediation, realization that there is no significant problem, or a decision that additional observation is warranted. An IDD diagnosis may have occurred in many different service systems, from the pediatrician's office during a well child visit to schools, regional centers, or neuropsychological or psychoeducational assessments from a mental health provider. Some may be identified by the courts or legal system following an offense. Some individuals with borderline or mild impairment may not be identified until much later in life, particularly in poor and underserved populations. So the absence of a childhood diagnosis does not mean that IDD is not present. Additionally, different states have different regulations and eligibility criteria. Some systems may only accept an assessment that occurs within their system. The result is that people with IDD and families may have to go through many different doorways to try to find appropriate services. There are many assessments for determining intelligence and adaptive functioning. These assessments have to be administered by qualified professionals. Some of the most commonly used today are the Wechsler scales for adult intelligence, but they have also been criticized for relying heavily on verbal and motor tasks, which may make them less valid for assessing the range of cognitive abilities for people with verbal and motor deficits. So if the person does not primarily use verbal communication or speaks another language, it is important that tests are selected that do not rely on verbal communication. Similarly, a person with motor deficits will need assessments that do not rely on timed tests. It is also important to consider the floor of an assessment. This is the lowest possible score on the test. Some tests are designed to have lower floors than others. Where this becomes a problem is if the person's true abilities are near or below the floor of the test. The test will not be able to provide an accurate assessment of the person's strengths or weaknesses. We've just outlined some screening and assessment processes for IDD-related support needs. However, we know that identification, diagnosis, and service planning of people with IDD is quite challenging. Delivery of primary care to people with IDD presents distinct difficulties to the providers. Even basic communication may be a struggle because they may be nonverbal or use assistive communication devices, such as picture systems or computer programs or tablets, that the provider may be unfamiliar with. Depending on the person's specific cognitive level and home and occupational resources, he or she may have more or less facility with communication. Some people with IDD also have complex and chronic medical comorbidities, such as chronic lung disease, seizures, and complex feeding problems that may require reliance on technologies such as tracheotomies, home oxygen, and gastrostomy tubes. These multiple health-related needs require intensive coordination of services and therapies, and often prove time-consuming, detracting from a focus on screening for trauma and related behavioral or mental health conditions. The person's Medicaid or other healthcare program may offer care coordination through entities called Disability Care Coordination Organizations, or DCCOs, which may be able to help coordinate services to ensure that trauma-related needs don't fall through the cracks.